Good day, everyone, and welcome to Implementing National Quality Policy and Strategy, a focus on stakeholder engagement and situational analysis. Thank you for joining us from wherever in the world you may be joining. It's so exciting seeing in the chat people chatting in the countries they're coming from, and I encourage you all to keep doing that as you're coming into the session today. So a quick word of welcome. This webinar is sponsored by the Local Health System Sustainability Project, also known as LHSS. That's USAID's flagship initiative in integrated health systems strengthening, focusing on increasing financial protection, increasing population coverage, and increasing coverage of quality essential services in priority countries around the world. So a big thanks to USAID for providing us this webinar space and ability to connect together today. Before we review the agenda and get into the session today, I turn it over to my colleague, Matt Jensen, to give us a brief orientation to the Zoom technology we're using today.
Thanks, Jesse, and thank you all for being here. Happy to have you. For those of you unfamiliar with Zoom, I'll do a super quick reference. You can see a screenshot of what Zoom looks like on your screen. Really what we want to highlight in this slide is opening the chat pane and making sure you're chatting either to everyone or to hosts and panelists. Hosts and panelists, if you have a tech issue or any issues with the Zoom or a question that you don't want the rest of the participants to see, and we'll be using the chat for Q&A instead of the actual Q&A function in webinar. So for that particular option, please do chat to everyone so people can see your questions, and then they'll get the same answer from the panelists. And if you have any tech issues at all, feel free to please chat to the host, which is me. And if you're having a tough time with bandwidth or it sounds a little laggy, feel free to turn off your video. And if you're dialed in by your phone, remember *6 to mute and unmute. Thanks, Jesse.
Thanks so much, Matt. I bet we're all pretty familiar with webinar technologies by now, but it doesn't hurt to have a quick review. So our agenda for today is up here on the screen. We'll begin with a review of the National Quality Policy and Strategy Framework, and Rhea Bright, Senior Quality Improvement Advisor from USAID Global Health Bureau, is going to walk us through some of the background history and resources available for NQPS. We'll then turn to Syed, the Head of Unit for Quality of Care at the World Health Organization, for some global perspective on NQPS policy and development journeys from around the world. We'll then get into the majority of our session today, looking at stakeholder engagement and situational analysis in Kenya. Lydia Okotoyi and Rhoda Kalondu from Kenyatta National Hospital, as well as the Kenya Society for Quality of Care, will be leading us through their experience in stakeholder engagement and situational analysis that they've undertaken over the past several years. We'll then look for some reflections and learnings from the case study from Bob Fryatt, Vice President of Health Systems and Policy at Apt Associates. We'll end our session today with a panel discussion and Q&A for everyone that's spoken on the webinar. So we hope everyone is able to stick around and have a lively discussion at the end of our presentations today. So with all that, our objectives for the webinar today are to reveal findings from the literature review and country experience survey and provide details on current practices in NQPS processes. We'll also look to describe best practices in stakeholder engagement and situational analysis, how these activities relate to other elements of NQPS, knowing that all of these foundational elements are certainly linked together and build off each other as we work towards establishing those NQPS. And finally, we'll share experiences from our leading country who has demonstrated success in stakeholder engagement and situational analysis, and back to that important point of linking the two together. So at the end of our hour here, we'll hope to have accomplished these three objectives. And with that, I will turn it over to Rhea Bright, who's going to walk us through some background on NQPS policy, strategy, and framework. Rhea.
Thank you very much, Jesse. So before going into the quality and governance framework, I just thought it would be helpful to, so if we could go to the next slide, please. Thank you. To provide a little bit of background about how we view quality in terms of health system strengthening. So I pulled this graphic from our newly released USAID Vision for Health System Strengthening 2030, and we released this vision in spring of this year. So our new vision, it really builds upon our past efforts, and it lays out a comprehensive approach towards improving health systems. So you'll see when you read this vision, you'll see that we've shifted our focus from the individual health system building blocks to focus more on the 3 health system intermediate outcomes of quality, equity, and resource optimization. And in terms of quality, our investments date back several decades, but for the purpose of this webinar, we're going to focus on governing quality, which is just one of our focus areas. Next slide, please. Thanks, Jesse. Now, over the years, we've partnered with countries and with global stakeholders to improve quality of care. And so this graphic really speaks to a multi-year endeavor, which culminated with a workshop in Tanzania in 2016. And prior to the workshop, we had been working very closely with 25 Joint Learning Network countries to identify challenges and successes for governing quality of care, both at the national and at the subnational level. And then we brought together 11 of those countries for a workshop that was held in Tanzania in 2016. And so the purpose of that workshop was to really bring together those countries to be able to learn from each other and to discuss what were the countries' experiences and what had the countries identified to be essential elements of good governance for quality. So it was within this workshop, the one that took place in 2016, that the 8 stones for governing quality of care emerged. So you can see here, these on the graphic on the slide shows the 8 stones that came out of that workshop. And just to highlight a few for you, one of which was engaging non-state actors, as well as creating a culture of continuous quality improvement and making sure to link financing to quality. Though all of 8 of these stones were identified as essential components of governing quality of care. Now, next slide, please. Now, a couple years later, in 2018, WHO released the handbook for their global initiative on national quality policy and strategy. And this document was really developed to respond to country needs, where we were seeing countries were reaching out for advice on how they could inform their efforts around developing a national policy strategy for quality, or implementing their policies and strategies, or even refining them. So this global initiative was in response to country requests. And so the handbook was developed to provide a structure, and it outlines the 8 key elements that you see here on this slide. And that these 8 key elements are the elements that countries should consider when creating their national quality policy and strategy. And for the purpose of this webinar, we're going to focus in on stakeholder engagement and situational analysis. But you can see here that there's also the other elements include national health priorities, making sure that there's a local definition for quality, governance and organizational structure, as well as improvement methods and interventions, health management and information systems and data systems, and then also looking at quality indicators and core measures. Next slide, please. Now, more recently, and based on all of the learning that we've had over the years and speaking with the countries and trying to improve upon our support to countries, within USAID, we have worked with our flagship project from the Office of Health Systems, which is the USAID Local Health System Sustainability Project, LHSS. And we asked LHSS to conduct a comparative analysis of existing quality and governance frameworks. And that included the 8 elements of the WHO NQPS framework that we just walked through. And then it also includes the 8 stones that came out of that 2016 Tanzania workshop, as well as other frameworks. And so the purpose of reviewing these frameworks was really to develop an analytical lens or a framework that LHSS could use to inform their global stock-taking exercise of 36 USAID priority countries. And we asked LHSS to do this global stock taking specifically to assess country progress on their NQPS journey. And in a few minutes, Jesse is going to go through some of the results of that global stock taking exercise. But I wanted to point out two things on this slide. So you see that this graphic is the new framework or analytical lens that LHSS adapted from the existing frameworks. And you'll see that it builds upon those 8 elements of the WHO NQPS framework, because all 8 elements are represented here. And it also adds 2 additional elements highlighted in yellow. And those elements are continuous quality improvement and health financing for quality. And you'll remember seeing those represented on the 8 stones from the 2016 workshop in Tanzania. And so at this point, I just wanted to go in quickly into the next slide, just to highlight why we think that stakeholder engagement and situational analysis is important. For the sake of time, I'll just highlight a couple. So we know that stakeholder engagement ensures that the right people are contributing, and situational analysis really is important because it helps highlight or identify the local needs. And then it also is important because it helps to identify system strengths to leverage that can be leveraged for improvement. So at this point, I'm going to hand over to Jesse from the LHSS project to present the results of the literature review and the survey of the global stock taking exercise. Thank you, and over to you, Jesse.
Thanks so much, Rhea, for that history and background of NQPS, such a rich amount of experiences that have contributed to those over the years. So a quick review of findings from our analysis exercise that Rhea had just mentioned. So we scanned 17 country NQPS documents, 24 country survey responses from a comprehensive survey about current activity around that analytical lens and those topics in the analytical lens that Rhea had mentioned, and also reviewed 6 foundational documents like that handbook and other resources available that we know a good number of countries out there are following to establish these NQPSs. And through this survey and literature review, we found that 85% or 17 of 20 respondents to our survey had moderate to high degree of belief that their country had an effective process to engage key stakeholders. 64% of our respondents had a documented process to understand strengths, gaps, and needs to determine those system priorities. 65% had engaged patients and community members in the development and testing and implementation of those NQPS. We had 71% of our respondents that were planning to address social determinants of health, but only 54% actually allocating budget to do so, to follow through in those activities to address the social determinants of health. So a quick look at some of the numbers relating to our topics today that we found in those survey responses. I'll move on to talk a little bit more deeply about both stakeholder engagement and situational analysis, some of the learning highlights, effective strategies, as well as common challenges or opportunities. For learning highlights in stakeholder engagement in that area of the analytical lens, through the literature review and survey findings, we see that stakeholder identification does not always translate to stakeholder engagement. So countries are great at coming up with that map of stakeholders, thinking through who the key players in the system are, but maybe take some missteps when it actually comes time to engaging them meaningfully in the process. What we found for effective strategies for engaging stakeholders was that countries that created an effective governance structure to monitor that process were more effective in engaging stakeholders. Also, countries engaging stakeholders earlier on and having a clear role and expectation for how those stakeholders were going to contribute and what they might be responsible for throughout the process led to more effective and meaningful engagement of those stakeholders. We also saw the identification of a quality champion in the system that can motivate for change, a well-established, recognized leader in the country to really be the face and the driving force behind the initiative. Oftentimes was really effective. And we know it's important to deploy multiple mechanisms to capture service user feedback. So meeting people where they are out there in the field, wherever that may be, whether it's going to community meetings, whether it's doing surveys, whether it's engaging directly in a care setting, really using multiple mechanisms to gain the feedback of all the stakeholders that are involved, especially important. With all those strengths, we also saw common opportunities, and the biggest one was to involve more patients and community members in planning and implementation of the NQPS. So really getting down to that patient and community member level. And finally, and this was highlighted in the stats that I had just reviewed before this slide, securing adequate funding for involvement of those stakeholders. You know, we're setting expectations for them. We want to be able to fund their involvement, whether that's for transportation or some amount of compensation for being involved in NQPS development, but really having funding for these activities is especially important, but a common challenge across the countries that we studied. We'll quickly look now at situational analysis using that same framework. So the learning highlights around situational analysis were that countries undertake situational analysis, but don't always include the final findings or a final real situational analysis document in their final NQPS. So there is sort of an opportunity to include that there more directly, explicitly, and strongly. What we found to be effective strategies for situational analysis were to build on stakeholder engagement. So again, to shape that engagement of the stakeholders, they'll be contributing to situational analysis, and to really kind of make this an iterative process and to build on the steps that we've established before. We found that leveraging a variety of processes to identify gaps and strengths was effective, and that could be going to national literature, various sources of data from across the country, both qualitative and quantitative, but leveraging a variety of processes to gain that whole circular perspective. And having a dedicated team to analyze data and facilitate prioritization of the findings from the situational analysis, really, you know, chartering and dedicating a team to doing this activity was quite effective. Common challenges were adequate time and resources to complete this activity around situational analysis in the depth that it really should be done, to really understand the strengths and opportunities that exist within a country health system before moving on to the next step. And a real common challenge was limited data due to a fragmented information system or challenges in stakeholder engagement. So really common challenges that were out there. When we look at our findings from the literature review and the survey responses, this is what we're seeing. And I'll now kind of turn it over to Syed from the WHO, who's going to talk to us a bit about the global perspective and how WHO has been supporting NQPS over the past years. Shams, over to you.
Yeah, thanks very much, Jesse. Greetings, everybody. And thank you, Rhea, for walking us through some of the history. Just a few perspectives to share with colleagues. It's really very interesting to see all of these findings that are coming through from the analysis that you've conducted with the team, Jesse. Just to remind colleagues, as Rhea has highlighted, with the WHO work on national quality policy and strategy, it was co-developed with a set of countries. So it actually brought in that thinking from inception, as well as with technical partners. So it's certainly something that I know that most colleagues on this call will be familiar with, but I'd encourage you all to have a good look through the materials that are available. One of the things that we've always found in the technical support that we have provided to countries across the world is the necessity for granular level technical support on the elements that are described. And that is particularly why it's very interesting to delve deeply into these two elements that Jesse just went over. And particularly the situational analysis, of course, is such a critical element and foundational for national quality policy and strategy. And perhaps one of the things that's a particular challenge that we face and we need to address is how work on quality strategies and policies, which are critical, are aligned with overall national health policy and planning. Of course, that is emphasized within the WHO NQPS handbook, but it is something that we have to keep very much in the forefront of our thinking. The other area that, again, it's come out in some of the findings that were just described, is the resources that are required to, one, design, implement, refine, and re-implement a quality strategy. We know, of course, that it's a never-ending story and the journey continues. So it is important to consider the resource implications. It's also important to consider how national strategies for quality are examined and then help to refine iterations of national strategic direction on quality. And that's particularly then linked to some of the stakeholder engagement pieces that were outlined by Jessie. Country context, I mean, can't be can't emphasize this more. In each of the areas that we examine and in the technical support that we provide, of course, we always think country context, and that's why I'm really looking forward particularly to hear from the experience that's going to be shared from Kenya. But really thinking this through from context, it's also important to examine particular settings. And more recently, WHO has been looking at quality of care in fragile, conflict-affected and vulnerable settings. And that's an emerging area that requires particular attention and linkage with overall strategic direction on quality. The resource implications are profound, and the resource implications in the post-COVID world will be even more stretched. So this focus on the resources or financial aspects for designing and implementing national strategic direction for quality become really critical. And then also this strong focus on continuous quality improvement that was being mentioned, that can have a particularly important role in the post-COVID world, because I think that's another area that we may have something to add in terms of how we examine the COVID-19 response and hopefully at some stage the recovery from the COVID context. One final point that I would like to highlight is that the learning side of this work is so critical. And I'd encourage you all to examine the WHO Global Learning Laboratory for Quality. It does have an entry point into a wealth of information that can be utilized, lots of it emerging from countries. And this country learning, that is the focus of this webinar, really is emphasized within the work of the WHO Global Learning Laboratory for Quality. It's a resource for us all. Those are a few perspectives there for colleagues. Jessie, back to you.
Thanks so much, Shams, for offering that discussion around the importance of context, as well as an offering of the resource in the GLL. Certainly a helpful thing that's out there that I've taken full advantage of, and encourage everyone on the webinar to as well. So now we'll move into the main portion of our webinar today, and I think what we're all here for. We have Lydia Okotoyi and Rhoda Kalondu from the Kenyatta National Hospital and Society for Quality Healthcare in Kenya to share their experience around stakeholder engagement and situational analysis leading towards NQPS testing and implementation. So Lydia, Rhoda, I'll now turn it over to you.
Very much for having us from Kenya, Nairobi, Kenya. We're glad that we can share our experience at the national and at the referral institution. So I and Rhoda work at Kenyatta National Hospital, and we are both members of the Society for Quality Healthcare. And the hospital is a specialized referral teaching institution in Nairobi with a bed capacity of about 2,000. And we have 5,000 staff in addition to residents, students, and faculty from the University of Nairobi and the Medical Training Institution. And so the hospital established a quality assurance unit way back in 1982. And that was the first effort towards a structured approach in looking on matters, hospital management of quality. And later in the year 2017, we were both engaged in launching the Healthcare Quality Division, which ensures that care is safe, effective, and that indeed it is delivered with respect. So we have 5 units that support this division of healthcare quality at Kenyatta National Hospital. Next. The hospital has been having quality management system since 2008, where we got the ISO certification. It is a general certification for quality management system, not really specific for health, but we've tried to have it work for us by having performance measures that are health related. We also have the other certifications for medical laboratory, and we have internal quality auditors, both for the ISO 9001:2015 and also some for the Kenya Quality Model for Health. So these support in quality assurance, and there are also other activities with quality, continuous quality improvements like Gemba Kaizen and Lean Six Sigma approach in some of the departments, for example, in accident and emergency. And so as a hospital, on the right side of the screen, we can see the quality policy. That is all we had in the form of a policy. We actually later stated that this is a statement and not a quality policy. And so we need to have a quality policy because we relied on the manual, the ISO manual that had been adapted to KNH, which was more of not at the level of a policy document. So there was a big gap in this manner in addressing quality in a more wholesome way. Next slide. So our journey to having interest and just realizing that this gap needs to be addressed came from 2018. We had an opportunity of attending the ISQA conference that was at Kuala Lumpur, and we encountered the NQPS workshop by WHO. Both Shams and Nana were there, and we were able to go through the paces and the reason why this brings together all these aspects of quality that were in different departments, and we thought we'd lack this as a country, and also we lack this as a hospital. And so we embarked on a journey following that trip in Kuala Lumpur in 2018. So Kenyatta had some hard copies from this conference, and we got the interest of the leadership of the institution. Next. So following that conference, our CEO appointed some members to a committee to address the quality policy. And they were from various departments. We had clinicians, we had some who were in health information, just guidance from what the National Quality Policy and Strategy document outlines. So we had from various areas that represent the gaps that are there, those involved in clinical audits, looking at patient outcomes, and those who are involved in health, in the environmental safety, workplace audits, and the statutory requirements, that units that support that. Then also, we looked at the patient experience, and we had done a patient safety index. So for all these documents and reports, audits that supported us to get to know the situation analysis, they represented thematic teams or departments that it was part of their main mandate to support this. So they came in both with tacit knowledge and with also the audit reports. And so we got these come together, these teams, and we developed a draft document, and we sought stakeholder validation. However, we did not progress too much when the COVID-19 happened. We discovered it requires a lot of commitment from all the units, especially to have a proper implementation strategy. And so we have these documents ready, but yet to go through the required validation as far as the Kenyatta structures are concerned. But the hospital continues to have SOPs and guidelines and documents that indeed are part of how we'll be able to continue adhering to the policy when it comes to fruition, hopefully the next year. Next. This slide is just to help us appreciate as a country where we have come from. In 2001, Kenya developed the Kenya Quality Model for Health, KQM, and this was more of an expert-led program, and it was a standard. This was a quality of care standard, not a policy, and it was supported by the GIZ. At this point, the level 6, those are the referral institutions, and the experts and policymakers were engaged, not necessarily to the lower levels, including the professional societies were not engaged in 2001. Then later on in 2010, we had a revision of this. Actually, the revision was completed in 2017. This was a little bit more inclusive. There were 2 partners, that is GIZ and JICA, that is the Japanese government, using the Asian Africa Partnership. And the professional society were engaged in this review. And the document was almost ready. Then we realized that we had not engaged the community, and the patients' voices had not been heard. And so there was some effort towards the various levels of care, including level 2 and level 1, which is at the level of the community, getting to adapt the model towards what they could offer. And in 2019, we also had a landmark of development of the care certification and accreditation framework. That is actually in 2020. These just also lifted the bar on matters quality. And still at this time, we didn't have a concerted effort as a country towards a national policy. These later was launched. That was February last year. And towards the end of the year, with matters COVID, we had emphasis on the health worker safety. And so WHO came in to support health worker safety efforts, and the gap at policy level was big. And so the same unit at the national level that addresses health worker safety also deals with patient safety. And so together with the quality and standard division, they are now working on a national quality policy. It's actually called National Policy on Health Worker Safety, Patient Safety and Quality, just because our funding is from the health worker side. It is from the IPC WHO regional office. And this has been very inclusive. We've had professional societies engaged. We have had the various regulators. We've had the associations, and a few patient representations have been involved. We could go to the next slide. I think it has more concerning this. Yes, so the IPC office are the ones that have led this, the WHO IPC regional office. And the engagement has been more elaborate than the previous documents. And this is the first time we're having a quality policy. And we've had so far 3 sessions. Actually, currently I'm attending the 4th session, which is looking at the implementation, the strategy on how this will be implemented, with an emphasis on the M&E framework. And so we've had various people, like an ice ball, a snowballing effect, whereby when we discover a certain regulator was never involved at the very beginning, yet there will be players in the next meeting they are called. So it has been quite a moment of including the stakeholders in a more meaningful way than previously, but still the patient's voice is weak, but it is better than the previous. On our right is just a draft of the cover page. We are yet to do the graphics of the same, but that is the draft that we hope to be ready either early next year or end of this year. Next slide. Great, this just tells us how the various levels we had engagement during the policy development. From the national level, we had the policymakers and the referral institutions from which I belong to supported the formulation of the policy. And this for the previous standard, that is the KQMH, coming at the county level, the main players were the partners and the county health management teams. Then before getting to the community, we had the sub-county level whereby the various community toolkits and units had to be identified. The community toolkits involved a religious leader and the healthcare workers like the community, they choose and who support either house units or a group of about 10 or so houses, and that is not in throughout the country. A few regions where the pilot was done had an elaborate approach to the community. Next slide. And so a little bit on how at the KQMH pilot phase, the community approach was done, just to have a document that could be applicable, a standard that could be applicable at the level of the community. This was funded through a USAID program, the SQUIL program by LSMT in collaboration with the MOH. They focused on maternal health aspects and chose 4 counties. And they had the development of this standard embedded in a QI approach, whereby they would engage the community focal persons and get the toolkit that had those specified members. That is, they had either a gatekeeper, whether religious or a teacher or a leader, a focal person who has a voice in the community. Then they'll have the healthcare worker, the extension healthcare worker who is allocated to that group. And then they would have a third person. So they would have all these groups support the unit in conceptualizing what the problem was. They could come out with a problem statement, and then they collect data, and then they then try to address the gaps in the care. And so at the level of the problem statement, they were given ideas about the best practices, whether it is to do with hygiene or nutrition or maternal health issues, because it was more of an MNCH approach. And so it was quite iterative, and they later produced the document that supported the community level standard. And so this was at the level of the standard. For the policy, we have not yet gone that deep to have community clearly delineated. It is more of having patient groups that are represented as a voice as we develop the policy in Kenya. That's a table on the right. It just shows the picture of the standard of the Kenya community model for health. Next. I think this should be a slide that Rhoda can continue just to discuss a bit about the challenges with limited data access. Rhoda, you're welcome.
Thank you very much, Lydia, and good evening, good morning, good afternoon, everyone, from wherever you are. Thank you for listening and thank you for logging in. So this is just a slide talking about the challenges we encountered, both at the national level and at the KNH level, at the hospital level. Remember, Lydia has taken us through the national level and at the hospital level and where we are at the moment. So one of the biggest challenges we encountered was the health information system. We realized that we have a very weak health information system and there was variation in reporting. We also lacked a feedback loop. So what did we do? We decided to look at the data that had been published and anecdotal data. We also realized that stakeholder engagement at that point was very crucial, so that as we pick this data, we know what represents them and what can be used for decision-making. We also realized that there's a lot of wealth of information from developed countries. So using expert opinion, using WHO guidance, learning from other countries to fill in the gaps, that's what we used. And one of the key lessons that we took home was that in the M&E, monitoring and evaluation framework, we really need to improve or deploy strategies to improve our documentation and strengthen our data collection system and get data that can be useful for decision-making. Next slide, please. Great, so this is one of the areas that we've participated in is in policy development phase and also the policy implementation phase. Right now, Lydia is involved in the policy development phase for the National Patient Safety Policy and Health Worker Safety. And these are some of the key take-home lessons that we've learned at the development phase, that the funding from partners is very crucial. Without funding, it's very difficult to move the agenda or even to develop a policy to be able to be adopted all through. It requires quite a lot of funding. We also realized that stakeholder engagement is very crucial. Although it was less comprehensive in the documents that Lydia has talked about, it was not the patient's voice was not captured very well, or it was not resonating very well. And there was minimal local data and limited local voice. There was minimal frontline healthcare worker engagement, and there was also minimal patient-reported outcome measures. Those are some of the key lessons we've learned, and we hope as we develop other policies, as we develop other policies, we should be able to pick from the lessons we've learned and change that. So at the implementation phase, which is also part of the role that we do at the hospital level, one of the things we've come across is that the community voice was heard in some of the places, like in the piloting phase of the Kenya Quality Model for Health. The community voice was heard through the community healthcare workers, the community, the kits that were being used. So the community voice was really captured very well, and we got that. I've seen a question about community being who participates in that, and yes, the community voice was captured there. We also realized that there are different funding interests. The funding partner for the development phase is not necessarily the funding partner for the implementation phase. And we do appreciate that. As Lydia took us through the processes from 2001 up to where we are right now, we've had different funding partners, and we appreciate that. And then there was the issue of inadequate resource allocation, and also data was not systematically collected. Therefore, it was ineffective for decision making. And one thing we also appreciate is that we've learned about administrative growth, whereby we have to pair our performance to this quality and safety. And there was a lot of CQI. And I've seen a comment from Mira Shah. Thank you very much for that. Yes, Mira Shah, there's a lot of CQI currently happening at some level, but we still have challenges in getting it documented. So documentation is quite a big challenge. I'd like to hand it over back to JC. I think we're done with the Kenyan picture. Thank you very much.
Thank you so much for sharing your experience with us, especially the points around engaging the community and working with fragmented or inadequate data systems. Those were two challenges that we really found across countries, and congratulations on the success that you've had overcoming those challenges in Kenya, and thank you again for sharing those lessons with us. I'll now turn to Bob Fryatt, who's going to offer some reflections and learnings from that country case study, really helping us pull out the salient learning points that Lydia and Rhoda had covered. So Bob, I'll turn it over to you.
Thanks very much, and thanks very much for asking me to participate in this very fascinating case study from Kenya. And I'm just going to pick, there's lots that we obviously could talk about there when it comes to good practice, and but there's just a few points I thought I'd just highlight. First, what I found fascinating is the description in that journey around how the governance approach changed over time. Initially, we had a description of quite a sophisticated approach within a hospital with a quality assurance unit and certification programs and a variety of quality improvement programs, but that wasn't enough. It had to go out and broader, become a more national governance process, which we saw nicely described there. The second area that I found very interesting is that when they decided to do a situation analysis as part of this more national outreach, it was done with a dedicated team so that it had time and effort could be put into it to done seriously. And then they also got validation of the results from this various stakeholders. So it clearly was done purposely to actually make it stronger and very inclusive in the approach. And again, I'm showing good practice there. Then what I found interesting is that they then expanded the number of champions for quality by going, it wasn't just at the national level, they had national, county, sub-county and community levels. By reaching out, you get this a bigger group of champions for quality. And again, more inclusive processes across the country, which is so key to improving, building a culture of quality across a health system. And then building on that inclusivity, when it came to the community approach that we saw presented at the end there was a good emphasis on inclusivity, engagement, and actually an iterative approach across the country. So there wasn't just coming out with one size fits all, but actually customizing to certain community needs and having that iteration within the community. It was so key for improving some policies on quality. And then lastly, I think the point that I think Shams also emphasized there's lesson learning, there's learning, and that learning continues. In particular, the need for dedicated resources. I mean, improving quality and continuing improving quality needs dedicated money, budgets, it needs dedicated people, and it needs dedicated data. And if you don't get that, you're not going to get your the achievements that you wish. And also, it's a never-ending journey. There's no end to this. This stakeholder engagement, community engagement will continue. That's clearly seems to be the intent in Kenya, and that's, I think, good practice that we can all learn from. Anyway, there's lots more, but I'll leave it as that and hand back to you, Jesse. Thanks.
Thanks so much, Bob. Certainly important points that you've pulled out, and just what I was hoping you'd highlight. So thank you so much. We'll now move into a panel discussion or Q&A session. So if there are any questions for our Kenyan presenters, as well as any of our other speakers who are still on the line, I'd ask you to use the chat to put those questions in. We have had a very active chat so far, lots of resources being shared. So I'd encourage that to continue. So thank you so much for lending all these resources. We do have one question, and this goes to Lydia and Rhoda. What is the Kenyatta Hospital's approach to measuring and addressing experience of care? Are patient welfare committees with affected individuals engaged in addressing patient concerns? So any detail or information you can share would be helpful.
Thank you, Jesse, and thanks for the question. So we both have a reactive and proactive approach to how to manage patient feedback. So for the reactive is the customer complaints and compliments that are analyzed and responded to. Some conclusively at the level of the unit, but some have to come to a dedicated team called patient affairs or the communication and marketing team. If it is more clinical, then they go towards patient affairs. So the last 3 years, we've attempted to do patient experience surveys and to be able to measure the experience on various parameters through the care. But we've realized we can improve, we make them thematic for specific areas, for example, for the cancer patients only, so that we have tools that are not very generic for everywhere. So we are still having learning step on getting good surveys on patient experience, because as a hospital, we've always done customer satisfaction, which is not as informative and which does not lead to the CQI that we so desire. And so we continue growing. Soon we'll be doing, we'll be adapting prompts for breast cancer patients. And so it will also be a learning journey to see how we can use some of those skills to the other areas. Then we are also using, these are mostly paper-based. We hope to get mHealth approach towards feedback and response. We just had that engagement, and we hope by the end of next year that we will have had one run using the phone responses, because most Kenyans have smartphones. So we are yet to optimize all the technology we have towards getting to hear what our patients want to see. I think that's what I can say, unless Rhoda has something more. Thank you.
Thank you so much. I appreciate the sort of marriage of using both qualitative and quantitative data to get that full picture of patient experience. A follow-up question right around that point: are patient experience data shared with frontline staff? And if so, how often?
Rhoda, do you want to take that?
Yes, thank you very much for that question. Yes, we do share the patient experience data. We do our audit survey research every year. We do 1 or 2 indicators, and we share that data real time. Once we get it, we disseminate the information to staff. So like for last year, we took 2 indicators from the patient-centered care guidelines and looked through the patient experience. What was the patient? How did they feel? Did they feel like they were respected? Did they feel the coordination of care and access to care was adequate? And we had a few indicators that they asked, and we asked the patient. We had a total of 390 participants who gave their input, patients that is, who gave their input. This was both in the outpatient and the inpatient setup. And we disseminated this information back to the staff and give them the feedback. And right now, some of the areas that patients highlighted as areas of concern or gaps for improvement, we are trying very hard to bridge them and to bridge in the gap. But as Lydia said, we need to do it better. We can do it better and look at patient-reported outcome measures and probably report them more real time if it can be able to be captured real time. So at the moment, we have developed a patient management system, feedback management system, and it's an online one. It's still in the process of development before it's been rolled out. And this one, the patient will be able to give their feedback real time, talk about their experience when they came to the clinic, what was the experience, and we should be able to address any concerns that they've raised or any feedback that they've generated real time. So it's still a work in progress, but yes, we do share the data with the frontline staff.
Thank you so much for addressing that follow-up question. I want to change topics a little bit and address a comment that had come on earlier on in our presentation. So many people out there, patients, community members are, leading busy lives, and it may not, it may be challenging to engage in supporting the development or providing feedback on this journey to establish an NQPS. Any thoughts from all of our panelists about the sort of right cadence or frequency to involve these stakeholders? How much input should we be really expecting, and how often should we be gathering our stakeholders or asking for their perspective or opinion about the strengths or opportunities or what's important to them in our healthcare systems? So I'd open that up to all panelists about what the right frequency or duration or cadence of stakeholder engagement might be along this journey.
Jesse, happy to just jump in with a quick thought here. It's a really important question. My initial thought would be that it's a prospective approach, and actually it would be depending on the real solutions that come from those engagements. So those human interactions that are taking place within the engagement processes needs to be focused on the longer term, and the best way to secure that engagement is to secure change and positive change. So I know that some of the experiences that have just been shared by Lydia and Rhoda speak to that, because it's as Bob was highlighting, it's a never-ending journey, right? So that engagement process, and particularly the human level interactions, have to see some immediate return on investment on the engagement. It's not engagement for the sake of engagement. It's engagement to enhance the quality of health services. And it's engagement with patients, families, and community. So this whole process would need to be considered in the context of wider engagement and empowerment mechanisms within communities as well. Complex, but more is better, more frequent is better, but it has to have some meaning, and it has to be meaningful. Over from my side.
Thank you so much, Shams, and I think that reinforces some of the comments that you had made earlier around context being key here. So we need to understand, how, when, and where and why we're engaging these stakeholders, and understand the context that we're all working in together. So again, a call to the audience for any comments or questions that you may have. Our next one is coming in, and Martin Asumba is asking, it's great to expand every effort to create the policy and strategy documents for quality of care. Translation at implementation phase, where the aspirations infuse into clinical practice and patient experience, can be a challenge, especially with health information system weaknesses. How have you addressed that challenge at Kenyatta? So going from actual, we have a policy and a strategy, now we need to implement that and translate it into clinical practice so the patients can experience the benefits that come along with this this structure. Any thoughts there about how you've made that translation from policy and strategy to action at Kenyatta?
Thank you, Martin, for that question. I think the last comment that Rhoda gave in her slides, that there's been a bit of other administrative growth in that the institution, whatever is happening at the front line is determined by leadership, and whatever structures are there to report outcomes and for the core mandate to be delivered in a manner that offers fidelity to our mission, that is to optimize patient experience as they come for their care. And so I'm thinking for the case of Kenyatta, it is a matter of small bit growth all over, whether it is administratively or whether it is to do with the thematic areas, the specialists, and all that when they're able to do their role well, then the policy just comes to cement the gains. Yeah, because already there was a quality, a standard, there was a quality management system, but bits and pieces were missing here and there. And so I think a big role of a quality policy is to have various aspects talk to each other and to create synergy, and to have the outcome or the patient's journey at the end as our desired outcome, that we are not just looking at each person in a silo way providing their care, but there is safety across the transitions, and that there is effectiveness as we continue to have multidisciplinary teams come and see this patient because we're in a specialized institution. And so I see already the other activities that are happening being woven together in this policy. And then beyond that, we will get commitment, which should be able to have direction at the level of appraisals or at the level of strategic planning, that there'll be specific measurable aspects in those quality of care domains that initially were being counted as either morbidity, mortality, admissions, but now we will have other more domains that are specific to what will make the patient or the department improve, because the gradual improvement has not been captured explicitly as it is now. So I think the aspects of the quality policy is just to bring this together and to have a proper monitoring and evaluation, that we can be able to embed that in the other strategic documents that are administrative, but now they'll have better guidance because of the quality policy. Let me stop there as an attempt to answer that very big question on how we do it to have it have meaning to every other patient and to every staff who comes to work at Kenyatta. Thank you.
Thank you so much for offering that that detail there, Lydia. Especially important. You know, we can develop all the policy and strategy we want, but unless we translate that into meaningful action, it's not going to get anywhere. We are very quickly approaching the top of the hour and almost at time. That really flew by. So thank you, everyone, for attending today. A big thank you to all of our panelists, especially our colleagues from the Kenyatta National Hospital, for sharing their experience. A quick little bit of follow-up here. I ask that you take just a minute to fill out our post-event evaluation that will automatically pop up in your web browser once you close the Zoom session for today. So your feedback is important and will help us design and execute further webinars. Also to mention that today's webinar was recorded, and a recording of the webinar will be uploaded to the LHSS website, as well as shared with everyone who registered. And if you've attended today, please feel free to share that recording with any colleagues you think may be interested in the rich learnings that have come out through our discussion today. So with that, just a big thank you to our attendees and to our panelists, and I hope everyone has a great remainder of their day. Thank you again all for being with us.
Thank you.
Thank you.